even if a child is snoring, that is sleep disordered breathing. And children with sleep disordered breathing have 10 times the risk of learning difficulties in comparison to children with good and deep sleep. And it's not just academic ability, it's not just about the craniofacial profile, it's not just about the mouth breathers going to have crooked teeth, because mouth breathers do tend to have crooked teeth because the tongue hasn't shaped the maxilla. Crooked teeth is not just because the teeth are big. The issue with overcrowding of teeth is because the jaws are too small, and a mouth breather will tend to have a V-shaped jaw and a high upper palate. And if we look at a study again that was published, I think it's in the European Journal of Pediatrics, and Dr. Christian Guilleminault was one of the co-authors. He looked at children who died as a result of sudden infant death syndrome. And all of the children who died abruptly, they died abruptly due to hypoxia during sleep because of compromised airway. The only thing that they had in the days preceding death was a runny nose.
Welcome to Afternoon Tea. I'm Dr. Linda, and I'm an emergency physician from Sheffield, and I'm here with my lovely co-host, Dr. Erica, a GP from the West Midlands, and we are both lifestyle medicine physicians. In the chat below, let us know where you're joining in from and what cup of tea you're having tonight. I'm having an Earl Grey one. And what are you having, Erica?
I actually just have some hot water today. And I see we have a very international audience today, which is so exciting. So hello, and we'll just tell you a little bit about Afternoon Tea. Afternoon Tea with Docs was born through Linda and my shared passion for evidence-based lifestyle medicine, which prevents, treats, and at times even reverse chronic lifestyle-related diseases like heart disease, diabetes, joint pains, and many more. And we are here every Sunday at 5 p.m, and our mission is to support you to improve your health, one conversation, one habit at a time, with the knowledge and experience of experts around the world.
And today we are so honored to have Patrick Mckeown join us to talk about breathing and its relationship to asthma, sleep, anxiety, and childhood development. Patrick is the president of Buteco Professional International. He's also a member of the management board and the advisory faculty of the International Academy of Breathing and Health. Patrick was educated at Trinity College in Dublin and later studied in Moscow Clinic of late Professor Konstantin Buteco, the founder of Buteco Breathing Method. He was awarded a diploma in the Buteco method by Professor Buteco himself. He has written 8 books, and his new book, The Breathing Cure, is coming out in February. Welcome, Patrick. Thank you for joining us today.
Thanks very much, Dr. Linda. It's a very embarrassing introduction when I'm hearing my own bio, but maybe it makes me feel old. But I think we have plenty to talk about over the next hour or so. So in terms...
Sorry, we have a little poll just to start off the event with. And you're going to be able to see the poll just next to your chat that will pop up. Right, can you see the poll? So we would like to ask you, how do you breathe, through your nose or through your mouth right now? And do you get a dry mouth when you wake up in the middle of the night? Do you feel like you have to drink? We would love to see your answers. And it's coming in. All right. Very interesting. As we have a lot of people here who know Buteco method, I can see that they answered they are breathing through your nose. So Patrick, you have taught them well.
Okay, I think the answers have all come in. We got a few more coming in. Right, okay.
So interesting. We have 85% of the people are nasal breathing here, 15% mouth breathing. And we do have 43% of the people who wake up with a dry mouth still. And 28% of the people do snore and 72% do not snore. So that is quite in relation with the nasal breathing, that's 85%, and those who don't snore are 72%. So good correlation there. Very good, thank you, that was fun. So we'll start with then the importance of nasal and mouth breathing and how does it affect our whole body. So could we ask you, Patrick, what is the importance of breathing correctly and how does it affect us?
I suppose it's about going back to basics, and when we consider the function of the mouth in terms of breathing, the mouth doesn't offer any function. The mouth doesn't moisten the incoming air, it doesn't warm, doesn't regulate volume. Mouth breathing doesn't harness nasal nitric oxide. It activates the upper chest. It's very inefficient. It's very uneconomical breathing. And despite that, and I know the poll there, in terms of 15% of people breathing through their mouths during the day, we don't have a figure for the adult population because it hasn't been studied very extensively. And I can only put my hand on one study. For children, and that refers to the photograph that we're looking at, the instance of mouth breathing in childhood ranges between 25 and 50%. And from the Breathe Institute, you'll see the diagram at the top. The image to the left refers to good craniofacial development. And you see that the tip of the chin is nearly towards the point of the nose. It's nearly as far forward as the point of the nose. Sorry, it's the other one. So if we look at the nose breathing profile, the diagram in blue, and we're looking at, when you're looking at here, you're seeing that the lips are together, but you're seeing a really nice facial profile. And here we can deduce that the airway in the nose breather is going to be much better and not compromised in comparison to the airway in the mouth breather. So the mouth breather here, you see that the nose is crooked. And the reason that the nose is crooked is because the maxilla hasn't developed forward enough. And the maxilla is the top jaw. And as the maxilla hasn't developed forward enough in the face, the mandible, which is the lower jaw, is also set back. But if the mandible is set back like this, what it is encroaching on is the airway. And the issue with the airway is really when it comes to sleep. Because our airway doesn't collapse during wakefulness. It doesn't collapse as we're awake, but there is a propensity for the airway to collapse during sleep. And anatomically, the individual here who is a mouth breather would have a much greater risk of collapse. And with that, if it's a partial collapse, it's called a hypopnea. If it's sufficient to drop blood oxygen saturation down by about 3% or more. And if it's a total collapse lasting for 10 seconds, it's an apnea in adults. Now, we really need to be looking at the incidence of sleep apnea because this is one condition that's often undiagnosed and it has a huge impact on health, whether it's cardiovascular health, diabetes. It's linked with dementia, for example. It's linked with chronic fatigue, with fibromyalgia, with depression. And if you look at the research of obstructive sleep apnea, you will see that it affects many organs and systems of the human body. The instance of obstructive sleep apnea from a Swiss study with males aged up to 50 years of age was 26%, but men over 50, between 50 and 70 years of age, it was 43%. And females aged, I think it's 30 to 50 years of age, is 9%. But when females post-menopause, their sleep apnea, their risk of sleep apnea increases 300%. So with females aged over 50, it's about 27 to 30%. So when you're looking at those statistics and how we breathe during childhood is going to influence our risk of sleep apnea later in life. I was the child on the right-hand side. I was the mouth-breathing kid. I was growing up with asthma. And if you have asthma, it's not just isolated. Inflammation is not just isolated to the lungs, but you're more likely to have nasal congestion. And if you have nasal congestion, if your nose feels stuffy while you breathe through it, you're not going to breathe through the nose because the air hunger is too uncomfortable. So you switch to mouth breathing. But when you switch to mouth breathing, you're not able to rest your tongue in the roof of the mouth. And it's when the tongue is resting in the roof of the mouth, it's the pressures exerted by the tongue as it rests in the roof of the mouth, which helps to drive the shape of the face forward. So aside, when we're looking at this, it's not just about aesthetics, but the face on the left is a much more attractive face. But the face on the left will also function much better than the face on the right. I have a crooked nose, my maxilla is set back, my mandible is set back. I had obstructive sleep apnea in secondary school and also in university. And the problem with obstructive sleep apnea is that it can impact behavior and it can also impact concentration. And even if we were to look at a study more closer to home by Karen Bonnock that was published in the journal Pediatrics, and she looked at 11,000 children in the UK, and children with sleep disorder breathing, if untreated by age 5, these kids had 40% risk of special education needs by age 8. So the photo on the bottom is a guy called David, and he was the son of a maths professor. And the photo to the left is him with his lips together when he was 10 years of age, and he's a nice facial profile there. But when he was 14, he got a hamster or a gerbil as a birthday present, and he kept it up in his bedroom, and he took an allergic reaction to it, and his nose got stuffy, so he switched to mouth breathing. And you see the change in the shape of his face. This boy, you see that his jaws are set back because the chin needs to be far forward in the face. Now, unfortunately, there are millions of children who are mouth breathing. When we look at 25 to 50% of studied children who are persistently mouth breathing, and it gets overlooked. And this has been debated in dentistry since 1909. So, when you think of children with sleep disorder breathing, and it's different for children in comparison to adults, even if a child is snoring, that is sleep disorder breathing. And children with sleep disorder breathing have 10 times the risk of learning difficulties in comparison to children with good and deep sleep. And it's not just academic ability, it's not just about the craniofacial profile, it's not just about the mouth breathers going to have crooked teeth, because mouth breathers do tend to have crooked teeth because the tongue hasn't shaped the maxilla. Crooked teeth is not just because the teeth are big. The issue with overcrowding of teeth is because the jaws are too small. And a mouth breather will tend to have a V-shaped jaw and a high upper palate. And if we look at a study again that was published, I think it's in the European Journal of Pediatrics, and Dr. Christian Guilleminault is one of the co-authors. He looked at children who died as a result of sudden infant death syndrome. And all of the children who died abruptly, they died abruptly due to hypoxia during sleep because of compromised airway. The only thing that they had in the days preceding death was a runny nose. But these children also had a very compromised nasal airway. And when you have a combination of nasal congestion, runny nose with a compromised airway, these kids have a high upper palate. And unfortunately, this isn't being looked at. Every newborn baby, we should be looking into the roof of the mouth. The baby should be checked if the baby is tongue-tied, because even for breastfeeding, and it all goes together, of course, with mouth breathing, because breastfeeding is not just about adequate nutrition for the baby, but it's also about manipulation of the muscles of the face necessary for craniofacial growth. There's a difference in terms of the baby feeding from the mother versus the baby feeding from a bottle. And I know society, and I'm not putting any blame on mothers here, but we do have to recognize that how a child breathes during childhood is going to impact that child for the rest of their life. So I might just take off this, if we can remove that. So when we look at breathing, we can look at breathing from, the perspective of the young child right up to the adult. And what forms good breathing? Well, good breathing is in and out through the nose, with the tongue elevated, pressed against the roof of the mouth. It's driven by the diaphragm. It's slow, it's regular, and there's a natural pause after exhalation. Good breathing is effortless. On the other hand, not so good breathing or dysfunctional breathing, it can be evident just by slightly faster breathing. So a slightly faster respiratory rate, upper chest breathing, mouth breathing irregular breathing. And if we look at the incidence of dysfunctional breathing patterns in the population, in the normal population, it's said to be 9.5% from a Cochrane review, but I believe it to be more. In the asthma population, it's 30%. And in the anxiety population, it's as high as 75%. So even if we were just to isolate the anxiety population, and there are millions of individuals with anxiety, with depression, with post-traumatic stress disorder, these individuals have a condition that is not only influenced, it's not only that their condition is influencing their breathing, but their breathing pattern is influencing their condition. And it's the same with asthma, because if you think of, say, a child or an adult with asthma, if you have narrowing of the airways, you feel that you're not getting enough air. And this is not when you're having symptoms. This is your everyday breathing pattern. So if there's any narrowing of the airways, whether it's due to increased mucus secretion or inflammation or constriction of smooth muscle of the airways, when there's narrowing of the airways, you feel air hunger. And in an effort to relieve the feeling of air hunger, you typically breathe harder and faster. But harder and faster breathing is feeding back into a breathing pattern disorder, which is going to feed back into the condition. So we have to bear in mind that with asthma, the condition is feeding in itself. With anxiety, the condition is feeding in itself. And I'm not saying that breathing is a cure-all, but what I am saying is that when we change breathing patterns with somebody with asthma, and firstly, it just doesn't make sense to allow a person or a child with asthma to continue breathing through an open mouth, because the mouth does nothing in terms of breathing. So we want the nose to moisten the incoming air, to regulate volume, to warm the incoming air, to harness the gas called nitric oxide. And nitric oxide was first discovered on the exhale breath in 1991. So it's a relatively recent discovery. And I'm not sure, should I just change the camera 1 second there? I just put it onto myself because I'm not sure what other people are seeing. So nitric oxide was first discovered on the exhale breath of the human being in 1991. Nitric oxide, it plays a number of very important roles. It's a bronchodilator in the human airways. Bronchodilator meaning that it helps to open up the smaller airways, but it also helps to redistribute the blood throughout the lungs. If we think of, because of gravity, and most of us human beings, we're either standing upright or we're walking or we're sitting, but we're upright. And because of gravity, the greatest concentration of blood in the human lungs is in the lower lobes. But if we're breathing through an open mouth, we're typically ventilating more so in the upper regions. And as a result, then there's a mismatch. When you breathe through your nose, you typically take the air into the lower regions of the lungs. And when you breathe through your nose, you harness nasal nitric oxide. And nasal nitric oxide redistributes the blood throughout the lungs. It was discovered back in 1988 by a researcher, Swift, that individuals who had jaw surgery, when their jaws were wired shut to force them to continuously breathe through their nose, the pressure of oxygen in the blood, the PO2, in millimeters of mercury increased by 10%. So nose breathing is helping to increase oxygen uptake. Nose breathing is more efficient because it naturally slows down the air as it comes into the body. Slow breathing is very important for mental health. There is a structure in the brain which was identified in March of 2017 by Stanford Medical School, and this structure is spying on your breathing. And if you breathe fast, this structure in the brain is reporting its findings to another part of the brain and is more likely to wake you from sleep. So individuals with insomnia, if they breathe hard and fast during sleep, are more likely to waken up, but also it triggers anxiety. So it's through the breath that we can really influence the emotional states. Nose breathing slows down the breath. With nose breathing, we tend to have a better biochemistry and our breathing tends to be more regular. And oftentimes people say, well, breathe in as much oxygen as you can and get rid of as much carbon dioxide as you can. But discovered back in 1904 by a Danish physiologist called Christian Bohr, that the pressure of carbon dioxide in the blood is a catalyst for the release of oxygen from the red blood cells to tissues and organs. Now, I remember as a youngster, I always had cold hands and cold feet. I was always mouth breathing. I had brain fog, and I never put my cold hands and cold feet down to my breathing. But it was because through the breath, when you gently soften and slow down your breathing, and when you slow down your breathing to the point of a light air hunger, you allow carbon dioxide to accumulate a little in the blood. This creates the feeling of air hunger, but as carbon dioxide increases in the blood, you start to notice that you have increased temperature in your fingers, so you can influence your blood circulation by changing your breathing patterns. And it's not about taking the big breath. You know, there's an awful lot of information out there. Breathe more air, breathe hard. But what happens when you breathe hard? If you breathe more air than what your body needs, you're not going to increase your blood oxygen saturation. With normal breathing volume, it's already generally 95 to 99%. But hard breathing gets rid of carbon dioxide from the blood through the lungs. And the loss of carbon dioxide causes blood vessels to constrict. And it also causes the bond between hemoglobin and oxygen to strengthen. So when we breathe too much air, our blood vessels constrict, our airways narrow, and also the bond between hemoglobin and oxygen strengthens, so less oxygen gets delivered throughout the body. And that's looking at breathing from a biochemical point of view. And I remember doing an exam, and I was nervous about going into it. It was one of my finals back, it's going back now quite a bit, 1996 or so. And just before I went into the exam hall, I went for a walk. And I deliberately took full big breaths because that's what I was hearing all the time. I was hearing it in yoga. I was hearing it in mainstream media. And I went for that 5-minute walk, taking full big breaths. And I walked into the exam hall dizzy. Now, I should have done the opposite. Now I have an exam preparation that we use. I often use it myself if I'm making a presentation. But what I do is I do the opposite. I sit down in the chair. I take my attention out of the mind onto my breathing. I gently start slowing down the speed of air as it comes in and out of the nose. And I slow down my breathing sufficiently to the point that I feel that I'm not getting quite enough air. That activates the parasympathetic response or the relaxation response. And it typically will do so in about 3 to 4 minutes. How do I know? Well, I feel drowsy, but I also have increased watery saliva in the mouth. So after doing that for a few minutes, and sometimes I can do it for 20 minutes, depending on the event, then I'll do a few breath holds to increase blood flow to the brain. So I down-regulate first to calm the mind, to bring a stillness to the mind, to bring my attention into the present moment. But then I up-regulate to increase blood flow to the brain. So there are many exercises in terms of breathing. And I suppose the one thing that we need to be looking at is, it's not just how you breathe in a studio, but it's how you breathe in your everyday life. How are you breathing when you walk down the street? How are you breathing when you're asleep? How are you breathing when you're stressed? And it's about paying attention to the breath. And also, we need to look at functional breathing from the point of view of 3 different dimensions. We, as breathing therapists, have always been in our own little silos. I was trained in Buteco originally, and my focus was all about biochemistry. So I focused on the biochemistry of breathing, and I ignored the biomechanics, and I ignored resonance frequency breathing or cadence breathing. The yoga instructor, Pilates instructor, etc., their focus is on biomechanics of breathing, but they tend to ignore the biochemistry of breathing, and they also ignore resonance frequency breathing or cadence breathing. The heart rate variability instructor is focusing on resonance frequency breathing, but not taking into consideration the biomechanics or the biochemistry. So when we look at breathing, we have to look at it in terms of the overall, and the overall is that there are 3 dimensions. And I just want to pull up a screen here. I'm just going to do a share screen. So just bear with me 1 second. So you see 3 dimensions of breathing. We're talking about the biochemistry, we're talking about the biomechanics, and we're talking about the cadence breathing. But interconnected with this is the nose. Because when we breathe through the nose, we tend to breathe light, and we tend to breathe slow. And this in turn is going to influence carbon dioxide. And nasal breathing, we have a greater amplitude of the diaphragm breathing muscle. For example, if you were to look at your chest and take a breath through the mouth, you'll typically see that mouth breathing is activating the upper chest. And mouth breathing is faster breathing. Whereas nasal breathing, we typically get a greater amplitude of the diaphragm. And of course, the diaphragm is not just a respiration. It's not just used for respiration. Diaphragm is very important for posture. It's very important for spinal stabilization. It's very common with individuals with lower back pain to be upper chest breathing. So that the diaphragm breathing muscle, when we take a breath of air into the body and the diaphragm is moving downwards, it's almost that the abdomen is braced like a pneumatic balloon, and this is to provide stabilization. So it's very important for support for the spine that we have functional breathing patterns, and functional breathing patterns means that we are breathing low. Earlier on, I said that as human beings, we tend to be upright, and the greatest concentration of blood flow is in the lower lobes. And if we're going around with the mouth open as I was, we tend to ventilate the upper regions of the lungs. And this leads to a poor gas exchange. So nose breathing allows us to take the air deeper into the lungs. And with nasal breathing, we also harness the gas nitric oxide, and that redistributes the blood throughout the lungs. So when we talk about the functions of the nose, there are many functions of the nose. And back in the 1970s, Dr. Morris Cottle, he made the claim that there were 30 functions, that the nose performs 30 functions in terms of the human body. So we talked about breathe light, we talked about breathe low, but also resonance frequency breathing. And this is centered all about stimulating the vagus nerve. And the vagus nerve is a nerve that's wandering throughout the human body. And 80 to 90% of the information from the vagus nerve is communicated from the body back to the brain. And with that also, we can influence by slow breathing, we can influence baroreceptors. And baroreceptors are pressure receptors in the major blood vessels. And we want our baroreceptors to be very sensitive to changes in blood pressure. But individuals who are not well, either if they're mentally, if they're emotionally or physically unwell, they typically have what's called low heart rate variability. But when we slow down our breathing to a cadence of between 4.5 to 6.5 breaths per minute, we increase vagus nerve traffic. Now, this in turn can reduce inflammation. And this was discovered back in 1998 by a neuroscientist called Kevin Tracy. And Kevin Tracy, he stimulated the vagus nerve electronically, and he found that he could treat conditions which were normally seen as untreatable, including rheumatoid arthritis. So if you Google Kevin Tracy, you'll find his work by electronically stimulating the vagus nerve. And we can also stimulate the vagus nerve through the breath. And there's a number of ways of stimulating the vagus nerve, but nose breathing is one of them. Diaphragm breathing, breathing low using the diaphragm is another. Breathing light to the point that we slow down our breathing and we feel a slight air hunger. And air hunger signifies the carbon dioxide is increased a little in the blood. That also helps to increase heart rate variability. And breathing slow. So I use the acronym, which is easy for people to remember. And it's light, slow, and deep breathing. So those of you of teenagers back in the 1990s, if you were a bit in the wild side, I'm sure you're going to remember this. It's LSD. So we need to be looking at the 3 dimensions of breathing and the impact that they're having in the human body. And the issue with breathing is that with breathing, we've very often been taught according to a tradition. And the problem with being taught according to tradition is that we feel compelled to adhere to that tradition. And we're afraid to go outside of the parameters of that. But I think research now is starting to catch up, and the science will catch up. And if you look at heart rate variability, we know that we can improve heart rate variability by changing breathing patterns. There's 30 years of research on this. And we also know that individuals who are unwell, they typically have reduced heart rate variability. So heart rate variability is regarded as an objective measurement of vagal tone, how well the vagus nerve is functioning. And, you know, it's also a marker of resilience. And some people are more resilient than others. And your resilience also determines and influences your reaction to stress. So as Herbert Benson said back in the 1970s, he said, stress makes people sick. And on the basis that stress makes people sick, relaxation helps to make them better. But how do you measure the impact that stress has on the human body? You can measure it via heart rate variability. And even individuals who went through a quite significant life event, such as a divorce, that event will reduce. Well, it depends on how it worked out, but you know, if it was not a very friendly divorce, that is going to reduce their HRV. People with obstructive sleep apnea have reduced HRV. People with post-traumatic stress disorder, people with diabetes, and you'll find studies on this. And then we have to ask the question, well, how can we improve heart rate variability? And it's coming back to changing breathing patterns in and out through the nose, breathing low, breathing slow, breathing light, light, slow, and deep breathing. And, you know, as somebody with asthma for many, many years, all the way through my childhood and into my early 20s, it made a huge difference to me by changing my breathing patterns to in and out through the nose. And sometimes it might seem it's so simple. Now, it's not just about nasal breathing. It's also about changing breathing patterns. And we use a breath hold time as a screening tool of breathing pattern disorders. And I'll just pull it up here. So just bear with me 1 second. So I don't have it to hand here because I closed off some PDFs and I obviously closed off that one. So I won't go looking for it, but I'll explain it to you. If you have a watch or a second hand, or maybe you have your mobile phone or whatever, and you're sitting down for about 5 minutes or so, take a normal breath in through your nose and a normal breath out through your nose, and pinch your nose and hold your breath. And measure how long does it take until you feel the first definite desire to breathe. And when you feel the first definite desire to breathe, to let go, and then you have normal breathing. It's not the measurement of how long you can hold your breath to a maximum. It's only the measurement of how long can you hold your breath following a normal exhalation until you feel the first involuntary contractions of the diaphragm. Okay, so here it is here. So you have taking a normal breath in and out through the nose, and then you hold your nose, and you're counting it in seconds until you feel the first definite desire to breathe, or the first signs of air hunger, and then to have normal breathing at the end. And it's worth your while testing this, because this is a pretty good indicator of functional breathing. And one study by a professor of physical therapy, Kiesel, about 3 years ago, he looked at 51 individuals, and his conclusion was that if your breath hold time is greater than 25 seconds, there is an 89% chance that dysfunctional breathing is not present. Now, if you measure the breath hold time, and we call it the BOLT score, the body oxygen level test, if you measure that in individuals with asthma, you'll typically see it's low. Any individuals with respiratory issues, it shows as a low breath hold time. People, for example, recovering from COVID, we have seen breath hold times as low as 3 seconds. These individuals can't string a sentence together. And I know earlier on we were talking about respiratory rate, but when the breath hold time is low, the respiratory rate tends to be high. When the breath hold time is low, breathing tends to be more upper chest. And individuals who have a habit of chronically hyperventilating tend to have a lower breath hold time. And breath hold time is also an indicator of exercise intolerance. So say, for instance, you have a patient, or, if you're doing physical exercise and you get out of breath quite easy, and if you measure your breath hold time, you'll typically see it's lower. So the breath hold time is kind of our measurement in terms of progress, in terms of breathing. We look at both the breath hold time. We also look at, is a person breathing lighter? Are they able to breathe functionally in and out through the nose? Do they have a natural pause following exhalation? Is their breathing effortless during rest? And We have different breathing exercises both during rest and during sleep, and also during physical exercise, because it's important to train breathing, as I said, not just when a person is in a studio, but how are they breathing outside of it, because the breath is something that we carry with us. Now, I'm sure many of you are interested in sleep, so I'm going to do kind of a couple of things about snoring. I'd like you to make the sound of a snore through your mouth. And to do this, you'll typically go like this. And now what I would like you to do is, I'd like you to close your mouth and try and snore with your mouth closed through your mouth. Try and snore through your mouth with your mouth closed. You will see it's impossible. You can't mouth snore. In other words, you can't get the vibration of the soft palate at the back of the roof of the mouth. You have to have your mouth open to mouth snore. So mouth snoring stops once you get your mouth closed during sleep. Nose snoring. Now make the sound of a snore through your nose, and it goes something like this. In order to make that sound, you typically speed up the respiratory rate and you tense the airway or constrict the airway. But now what I would like you to do is to breathe slow. I'd like you to breathe really slowly in through your nose and have a really slow and relaxed exhalation out through your nose. And a very soft and slow breath in through your nose. And a very slow and relaxed exhalation out through your nose. And continue breathing slowly in and out through your nose. And as you're breathing slowly in and out through your nose, try and snore through your nose as you breathe slowly. So try and snore through your nose as you breathe slowly. You will find that you can snore through your nose when you breathe slowly, but you will snore significantly less. The airway, it's not just about the airway. When sleep doctors are looking at sleep, whether it's snoring, hypopnea, apnea, upper airway resistance syndrome, they typically look at the airway. And they're looking at the diameter of the airway, how well the upper airway dilator muscles are working, etc. But they don't always take into consideration flow. If you were an engineer and if you were looking at a pipe, you're not going to just look at the diameter of that pipe. You're going to ask the question, what is the flow through that pipe? And if you think of people with low breath hold time, people with a low Bolt score, and that group is going to include people with asthma, no question. And because if there's inflammation in the lungs, the feedback from the lungs to the brain will reduce breath hold time, even though breath hold time is regarded as a measure of chemosensitivity to carbon dioxide. And keeping it that in simple terms is carbon dioxide is the gas that's in your blood, and it's the primary stimulus to breathe. So your body breathes based on changes in the accumulation of carbon dioxide. And if you're overly sensitive to the accumulation of carbon dioxide, your breath hold time is low, but your respiratory rate tends to be a little bit faster. So my point here is, if you have a low breath hold time, your breathing is typically harder and faster. And if your breathing is harder and faster, there's an increased turbulence in the upper airway, but there's also an increased negative pressure. Now, for many years, and this was one of the things that really I noticed back in 1998, I was a chronic mouth breather, waking up exhausted every morning. And that night, after I read a newspaper article, I think it was in the Irish Independent or the Irish Times, but I can't remember which one. That night, I wore Breathe Right strips across my nose, and I got tape, micropore tape, and I put it on my lips so that I would breathe through my nose. Now, it wasn't ideal because I went straight into it, just taping up my mouth, which was a bit stupid. But in any event, I was determined just to continue breathing through my nose. I woke up the first morning kind of still getting used to it. The second morning I woke up, it was the best night's sleep I had in many, many years. Nasal breathing is absolutely key to a deeper sleep and waking up more refreshed. And judging by the poll that Dr. Linda put out there earlier on and Dr. Erica, you've seen that up to 50% of people are breathing through an open mouth, waking up with a dry mouth in the morning. I think that's a real figure. I genuinely think that if somebody was to ask me what's the incidence of mouth breathing during sleep, I would typically say it's about 50%. Now I'm going to show you a paper that was published fairly recently in the journal Laryngoscope. And it's a recent paper, and it's looking at oxygen desaturation and the AHI index in mouth breathing versus nasal breathing during sleep. So just let me pull it up there. And I'm just going to do a scroll down. So they looked at 95 individuals. They had established obstructive sleep apnea, and they studied them over a 2-year period. And I'm just scrolling down through the results here, which are quite interesting. So out of 95 individuals, the amount of individuals who are mouth breathing solely was 11.6%. And if we look at their AHI index, which is a measurement of their sleep apnea severity, it's the number of apneas and hypopneas per hour of sleep, it's 52, and this is severe. And if we look at their blood oxygen saturation, their blood oxygen saturation is dropping down to 64%, which is extreme hypoxia. If we look at the incidence or the number of people who are breathing both through the nose and mouth, and it's normal that you will have a greater population. It's rarely that mouth breathing only occurs, but typically people switch from nose to mouth breathing, nose-mouth breathing, or they may be breathing both through their nose and mouth at the same time. 51%. And if we add up 51% plus 11%, we're getting a figure of approximately 63% there. So 63% of these individuals, and these people are young, and I'm talking about 45 years of age, 51 years of age, 48 years of age. So of the group, only 36% of them were nasal breathing, and 64% of them were either breathing solely through their mouth or switching from mouth to nose breathing or breathing both. If we look at the AHI index with the nose and mouth breathing, it's 42 events per hour, which is also severe, but it's less than mouth breathing alone. And if we look at the minimal drop to their blood oxygen saturation at 77% in comparison to 64%, it's still severe hypoxia, but yet it's not as severe as 64%. Nasal breathing alone, the AHI index is 27 events per hour, which is moderate to severe, but it's just bordering on severe. But at the same time, there's a huge difference between an AHI of 27 events versus an AHI of 52 events. And their blood oxygen saturation here is 78%. So there is a difference in how we breathe during sleep and obstructive sleep apnea. And I recently wrote an article with 2 ear, nose, and throat doctors, and we submitted it for publication because the whole field of sleep medicine has changed fundamentally in the last 7 years. Obstructive sleep apnea, and that means that you stop breathing during sleep. And that was traditionally seen as an anatomical, mainly as an anatomical issue. But in the last 7 years now, there's a recognition that one of the characteristics of sleep apnea is anatomy. It's called peak rate. And that's the suction pressure at which the airway collapses. You need your airway to be able to withstand a high suction pressure. You know, if you're breathing in sleep, you don't want your airway collapsing at the slightest inhalation of air as air is drawn into the lungs. But there are 3 non-anatomical characteristics. And the first of those is called loop gain. And high loop gain means how fast, well, it basically means your sensitivity to carbon dioxide. And you can measure this by virtue of breath hold time. 30% of the obstructive sleep apnea population have high loop gain. This can be indicated by having the individual measure their breath hold time. And if it's less than 20 seconds, it's an indicator of high loop gain. And what this means is that they have an increased chemosensitivity to carbon dioxide, that if they stop breathing during sleep due to collapse of the airway, as they stop breathing, carbon dioxide accumulates in the blood. And if they have an exaggerated response to the accumulation of carbon dioxide, when they resume breathing with such exaggerated ventilation that they go from high CO2 in the blood, which happened during the stopping of the breath, to too low CO2. And then the brain doesn't send the signal to breathe, and this can initiate a central apnea. But also, when the brain doesn't send the signal to breathe, the output from the brain to the upper airway dilator muscles to help maintain an open airway reduces, and that can contribute to an obstructive sleep apnea. The third phenotype is arousal threshold. And arousal threshold refers to the propensity to wake from sleep. Basically, are you a light sleeper or are you a deep sleeper? And in terms of the mortality, and a study published by the American Thoracic Society, and it's fairly recently, 2018, it showed that the individuals with the greatest risk of mortality during sleep was not the people who were holding or stopping breathing for a minute and lowering their blood oxygen saturation, but it was the individuals with a low arousal threshold. It was people with insomnia and obstructive sleep apnea combined. And we also know that when insomnia and obstructive sleep apnea combined happens, it increases the risk of depression. Now, you have to ask the number of individuals with depression who also have insomnia and obstructive sleep apnea, and it's their sleep which is feeding into the depression and it's their sleep issues that are causing their exhaustion, and this is feeding into their depression, as opposed to their depression causing their exhaustion. So low arousal threshold is how light a sleeper are you? Are you waking up from sleep due to the slightest change in pressure in the upper airway or the slightest change in increase of carbon dioxide, for example, if there's an obstructive event? We need to be sleeping deep, and breathing through the nose is key for that. And when we have the mouth closed and we have the tongue resting on the roof of the mouth, that helps to open up the architecture of the upper airway. So say, for example, if I look at the anatomy of the nose here, and when we're talking about, so you see this, the front facial profile here is the nose, you have the lips. And when you're talking about here is the hard palate and the soft palate. The lips should be together with the tongue elevated against the roof of the mouth. And this airway here, a good airway is the size of your thumb. That's a good airway. And a poor airway in different parts could be the size of a big biro, for example. The airway can collapse in 4 different places. One is the soft palate falling against the throat. Number 2 is the tongue falling against the throat. Number 3 is the epiglottis. And number 4 is collapse of the throat itself. Having your mouth closed with your tongue resting on the roof of the mouth is imperative to helping to maintain an open airway during sleep. And if you have your mouth open, you cannot have your tongue resting on the roof of the mouth. So what I would like you to do is to do this sound. It's popping sound. So in order to make that sound, you need to get your tongue elevated into the palate. And your tongue should be resting in the roof of the mouth, both during wakefulness, during physical exercise, but especially during sleep. And you should wake up with your tongue resting in the roof of the mouth. And for men, and just excuses or apologies to the females here, men should wake up with their lips together, their tongue resting in the roof of the mouth, and an erection. And it's very, very important, because if a man has poor quality sleep, he's not going to wake up with an erection. He's more likely to be, it could be a cardiovascular issue, which could be contributed to by obstructive sleep apnea. So I think if people were to ask me, well, where's all the research on that? The research is starting to come out. And one paper that was published by a Harvard medical doctor, Mckeown, quite recently looked at loop gain and sleep apnea. And I'm just going to see if I can pull this one up here. And I want to show you as well Karen Bonnick's paper. So 1 second. And he concluded that breath hold time, and any of your patients, or if you have a likelihood of sleep disorder breathing, look at your breathing during sleep. Don't wake up with a dry mouth in the morning. Measure your breath hold time and practice breathing light, slow and deep. And if you want, I'll give you a few minutes in terms of exercises that you could practice straight away. So I'm just going to try to do a share screen here. And so this paper here was published again. It's published back in 2018 and it's by Dr. Mckeown. And this is loop gain. Basically, if you have a low breath hold time, your breathing typically is faster, more upper chest. But if you stop breathing during sleep, it feeds back into your condition. So, for example, the interest about thing here is that, for example, a high loop gain helps to predict a favorable response to non-anatomical interventions. And what this means is that if you have somebody with obstructive sleep apnea, and they're focusing primarily on anatomical interventions such as surgery or mandibular advancement, they're not going to have a successful outcome. So there's a favorable response to non-anatomical interventions and an unfavorable response to anatomical interventions. And aside from the anatomical compromise, arguably the strongest determinant of obstructive sleep apnea is a hypersensitive ventilatory control system or elevated loop gain. But basically, it just means that you have an exaggerated response, an exaggerated ventilatory response to minimal changes in carbon dioxide. So your breathing during sleep should be light, slow, and deep, but how you breathe during sleep is determined by how you breathe during wakefulness. And people often say, well, how can I change my breathing during sleep? You change your breathing during sleep by practicing breathing exercises to improve your breathing during wakefulness. And we can start off, I can show you a very gentle exercise to start off with, and then I can show you an exercise to help decongest your nose if you want. You can open up your nose by simply holding your breath. And this has been known since 1923. So the first exercise that I would start off that's suitable for everybody is just a gentle breath hold exercise. And we use this also for symptoms of asthma. If somebody is starting to get a little bit of chest tightness, or if they're wheezing or coughing, we do small breath holds to help breathing recovery. So this exercise, I would like you to give it a go. You take a normal breath in through your nose and out through your nose and pinch your nose and hold your breath for 5 seconds. 5, 4, 3, 2, 1. Let go and breathe in through your nose and breathe normal for 10 seconds. And again, take a normal breath in through your nose and out through your nose and pinch your nose and hold. 5, 4, 3, 2, 1. Let go and breathe in through your nose and breathe normal for 10 seconds. And we shouldn't really hear anybody breathing. And again, take a normal breath in through your nose and out through your nose and pinch your nose and hold. 5, 4, 3, 2, 1. Let go and breathe in through your nose and breathe normal for 10 seconds. And again, take a normal breath in through your nose and out through your nose and pinch your nose and hold. 5, 4, 3, 2, 1. Let go and breathe in through your nose and breathe normal for 10 seconds. Okay. The next exercise is going to help decongest your nose. However, don't do it if you're pregnant or if you have any cardiovascular issues, high blood pressure, for example, or if you have very unstable breathing or panic disorder. It's a breath hold exercise similar to a child in a swimming pool going down underwater and coming back up. So you can check which side of your nose is more congested. Block one side of your nostril and breathe through it. And block the other side of your nostril and breathe through it, of your nose and breathe through it. And to decongest your nose, simply take a normal breath in through your nose and out through your nose and pinch your nose and gently nod your head as you hold your breath. So gently nod your head as you hold your breath and continue holding your breath until you feel a medium to strong air hunger. Continue holding your breath until you feel a medium to strong air hunger, and then to let go, but to breathe in through your nose and breathe normally then for about a half a minute or so. So just breathe normal. And even with a head cold, this will help. Now, nasal congestion is likely to continue until your breath hold time is 20 to 25 seconds. If anybody comes into me with asthma, I'll always say to them, I would expect you to cough, to wheeze, to be breathless, to have your asthma symptoms until your breath hold time is 25 seconds. And every time their breath hold time increases by 5 seconds, their symptoms reduce. Let's try that exercise again. Take a normal breath in through the nose and out through the nose, and pinch your nose and gently nod your head up and down as you hold your breath. Gently nod your head up and down. So you're just gently doing it. And it's not about stressing the body or anything like that, but continue holding your breath until you feel a relatively strong air hunger. And then to let go, but to breathe in through your nose. And then you wait a minute and you do it again. So to decongest the nose, we do that exercise about 5 or 6 times. And the wonderful thing about the human nose is that the more you breathe through it, the better your nose works. The more you breathe through it, the better it works. So I'll just wait a minute and we'll do it again. And then I'll show you another exercise just to see, can we improve the circulation in your fingers? Because it will give you an idea that when you breathe a little bit less air, when you slow down your breathing, can we activate the body's parasympathetic response? Can we activate the body's relaxation response? And as I said, people with insomnia often have a difficulty switching off. If the mind is agitated, it's difficulty to fall asleep. You know it yourself. If you have a stressful day, you go to bed that night and your mind is racing from thought to thought. And as a result, you're twisting and turning for part of the night and you wake up feeling exhausted. And if you wake up feeling exhausted, you're not going to feel calm. We cannot have a calm mind unless we have quality sleep. And this is not just for adults, but it's for children as well. And again, take a normal breath in through your nose and out through your nose, and pinch your nose and hold, and gently nod your head up and down, or you could move about. And of course, you don't do this if you're pregnant or if you have serious medical issues. And keep just gently holding your breath, keep holding your breath, keep holding your breath, keep holding your breath, as if you're underwater, you're swimming underwater. And keep holding your breath until you feel a fairly strong air hunger, and then to let go, but to breathe in through your nose. And we did that 3 times there. Try blocking one nostril, breathing through it, and try the other nostril. And you may notice that you're getting some relief there. You'll have to try it a few times. And if you're not getting relief, just hold your breath for longer. But we did a pilot study with this back in 2013. And it was 26 patients with asthma and chronic rhinosinusitis. And the pilot study, I don't have it here, but it was published as an abstract in the journal Clinical Otolaryngology, and it reduced symptoms by 70% at 3-month follow-up. And the reason that it's very important to get the nose working right is for sleep. If you have a stuffy nose, you don't just have a stuffy nose. You're also more likely to have sleep disorder breathing, and that's going to impact our concentration, our energy levels, and our mood. And what I would like to show you is the study by Karen Bonnock, which is a very interesting one, and the application that it has with children. And I'm just going to do a share screen. So this was a study that was carried out in the late 1990s, and it was published in the journal Pediatrics. And I think it's 2012 it was published in 2012. And she looked at 11,000 children from Stratford upon Avon in the UK, 11,049 children. And she looked at children who had sleep disorder breathing. If it was untreated in the first 5 years of life, it was associated with a near 40% increased risk of special education needs. This is the importance of good quality sleep with children, and nasal breathing is really an important factor with this. Now, of course, you're going to be saying to me that, well, what about the adenoids and what about the tonsils? And of course that plays a role. However, adenoidectomy and tonsillectomy, if a child does undergo, it's very important that nasal breathing is restored. Otherwise, the results of the operation is likely to be short-term. And the efficacy of adenoidectomy and tonsillectomy was only first determined in 2010, looking at a study published by Batterjee of 574 children. And post-tonsillectomy and adenoidectomy, only 23% of these children had their sleep apnea completely resolved. 27% of them. 73% of these children continue to have residual sleep apnea post-tonsillectomy and adenoidectomy. So my point here is that with sleep apnea, it's not just about the airway. There are non-anatomical considerations there, and that's what's happening now in sleep medicine with the recognition of high loop gain, arousal threshold, and also the functioning of the upper airway dilator muscles, which in turn is influenced by your breathing. Okay, so not how I have to talk, but I'm going to give you, say, a short 3-4 minutes just breathing exercise. And it can be a little bit uncomfortable. So if you're prone to panic disorder, what I'd say is go very easy with it, because it can be very good. For example, if you do have anxiety or panic disorder, to practice breathing exercises. This exercise is looking at breathing from a biochemical point of view, and you're going to feel air hunger. And all that's doing is signifying that carbon dioxide is increased in the blood. And as carbon dioxide increases in the blood, it's going to improve blood flow to the brain. So the objective here is that individuals who chronically hyperventilate, it can agitate the central nervous system, pain perception, and reduce pain thresholds. And before I forget it as well, women's breathing is different than men's breathing. And that's another topic. So for example, young females in days between days 10 and days 22 of the cycle, there's an increase in the hormone progesterone, and it's a respiratory stimulant. And that carbon dioxide can be up to these females, but of course the fatigue into anxiety. That's been written about 1905, but most of the research in breathing has been done by men. And also the research which has been done by women has failed to take into consideration the stage of the monthly cycle. And the other aspect about breathing then is postmenopausal. With females, anecdotal evidence is when females are breathing through their nose, that hot flashes and hot waking ups with sweat during sleep, it reduces. And that was the feedback that we're getting in. I haven't came across any papers on it, but it might be an interesting thing. We have to consider the balance of the autonomic nervous system. Slow breathing, light breathing, deep breathing helps to stimulate the vagus nerve, increase the sensitivity of the baroreceptors, resulting in a better balance of the ANS. And if we can bring the autonomic nervous system into balance, and if we can reduce sympathetic tone and improve that balance, we have to ask the question, what impact can we have on health? And we do that through the breath. So a simple exercise, I'd like you to give it a go. Don't have the air hunger to the point that it gets stressful, but you might feel it's a little bit uncomfortable, but it's the same as if you go for a walk. You could have, for example, one hand on your chest, one hand just above your navel. And I'd like you to really concentrate on the airflow as it comes into your nose and the airflow as it leaves your nose. So feel the slightly colder air coming into your nose and feel the slightly warmer air as it leaves your nose. And as you feel your breathing, gently slow down the speed of the air coming into your nose. And at the top of the breath, bring a feeling of relaxation to the body, that you have a really relaxed and a slow and prolonged exhalation. And then when you need to breathe in, take a very soft and slow, gentle breath in. Can you breathe in through your nose so slowly, almost that the fine hairs within the nostrils do not move? At the top of the breath, have a really relaxed and a slow and gentle exhalation. And again, as you breathe in so soft, almost as if you are hardly breathing any air into your body. Don't hold your breath or freeze your breathing. Just gently slow down the speed of the air coming in and out of your nose. And at the top of the breath, a total feeling of relaxation to have a relaxed and gentle breath out. Your objective is to take less air into the body. You're doing it correctly if you feel a tolerable hunger for air. And I'd like you to continue practicing it because I'd like you to see, can we influence the internal temperature of your fingers? Can we cause you to feel more drowsy? And can we influence the saliva in the mouth? In other words, can we activate the body's relaxation response, but also can we influence your blood circulation? 70,000 miles of blood vessels throughout the human body. Can you help to dilate your blood vessels by simply learning to breathe less? So you're really slowing down the speed of air coming into your nose. And at the top of the breath, a really slow and relaxed and gentle exhalation. And then a very soft and slow, gentle breath coming into your nose. Can you breathe almost as if you are hardly breathing any air at all? And at the top of the breath, a total feeling of relaxation and a very slow and relaxed exhalation. And the purpose here is from a biochemical point of view, that you practice breathing less air and light breathing. And that trains your breathing pattern so that your breathing pattern becomes slower, but it also reduces the chemosensitivity to carbon dioxide. And there's an inverse relationship between the sensitivity of your baroreceptors and the sensitivity to carbon dioxide. So I'm not sure if you got much out of that exercise, but normally when we're working with people, we're working with them over 2 hours or so, and we'd have plenty of practice. But at the same time, I just wanted to kind of give you a teaspoon of what was involved. Now, it's not just about breathing less air, but we also then bring in breathing low with lateral expansion and contraction of the lower ribs, and breathing slow to stimulate the vagus nerve, etc. And then we bring them in together without complicating it, but we need to look at the depth of breathing from 3 perspectives, not just from one. Okay. So I don't know if time-wise, it's 6:10, so I'm sure we're well over. And in terms of questions, so if I pass you to Erica or Linda.
Yeah, we do have quite a lot of questions in the chat. I do have one question. It might just be me, but can you clarify the breathing light and breathing deep? I think I'm a bit confused.
Yes. No, it's fine. So breathing deep, most people, when they talk about take a deep breath, they typically take a big breath. But if we think of the word deep, a definition of the word deep means far from the top. So in order to breathe deeply, what I'd like you to do is put your hands either side of your lower ribs. And you're putting your hands either side of your lower ribs. And as you breathe in, I would like you to gently push your ribs outwards. But you should not hear your breathing. In other words, it's not about taking the big breath, but it's about breathing low. So as you breathe in, your ribs are gently moving out. And as you breathe out, your ribs are gently moving in. And as you breathe in, your ribs are gently moving out. And as you breathe out, your ribs are gently moving in. And as you breathe in, your ribs are gently moving out. And as you breathe out, your ribs are gently moving in. So during rest, the chest should be responsible for about 20% of movement, and 80% of movement should be driven by the diaphragm. And the reason that I have you put your hands either side of your lower ribs is because it takes intra-abdominal pressure to push the ribs outwards. If I just have you put your hands in your front, you might be just pushing out your tummy and pulling in your tummy. So we want to get lateral expansion and contraction of the lower ribs by virtue of the pressure generated by the diaphragm. And by the way, the diaphragm breathing muscle is also connected with the emotions, but the diaphragm breathing muscle is also connected with the upper airway dilator muscles in the throat. So for example, individuals who upper chest breathe, they have reduced lung volume. And when you have reduced lung volume, your throat is more likely to collapse during sleep. And that's why obesity and sleep apnea often go together. Yes, with obesity, we do put fat deposits on the throat and we do put fat deposits on the tongue, but we also put fat on the belly. And fat on the belly impinges the movement of the diaphragm. And impinging the movement of the diaphragm, the throat is more liable to collapse. So we have to think of the airway as one airway. It's all interconnected. And if there's a dysfunction in one part of the airway, it can reflect in the other.
Great, thank you. Question in the chat about whether the breathing exercises that we've done, are they suitable for people with COPD?
Yes, the most suitable, it really depends on the person's breath hold time. For COPD, I would really encourage them to breathe in and out through the nose. And, you know, I would also encourage gently softening the breath and slowing down breathing and doing small breath holds. So the whole purpose with COPD is about, generally with people with COPD, there's some degree of reversible obstruction. It's not that their entire airways are completely, you know, irreversible obstruction. And what we want to try and do is we want to get reversible airway obstruction. We want to open up those parts of the airways that we can open up for better gas exchange to take place. Now, breathing low can sometimes be a little bit of a challenge with people with COPD, but if you breathe slowly, it's much more efficient in terms of the breath. Now, I'm just going to pull up something here just to explain this, because this is going to apply not just for COPD, but it will also apply for other conditions, including COVID. Now, so bear with me 1 second. You should see the diagram. I was looking for a whiteboard there, but I'm just going to use this. And so say, for example, if we have the respiratory rate here, and we have the tidal volume, which is the size of one breath, and that gives us minute ventilation. And we'll say that somebody with COPD is really caught for breath, or they're recovering for COVID, or somebody having a panic attack, etc. They feel air hunger and they feel suffocation. And it's normal for the human being that when we feel suffocation, we typically breathe fast and shallow. That's a normal reaction. So I'm just going to show what happens to alveolar ventilation, how efficient is fast and shallow breathing. So say, for example, this person is breathing 20 breaths per minute. And I'll say that the tidal volume here, it's quite shallow, it's 300 mil. And that gives us a minute ventilation of 6 liters. But the real question is, how much of that air actually got down into the small air sacs in the lungs for gas exchange to take place? To find that out, we have to subtract dead space. And dead space is 150 mil. So with this person here, they're feeling suffocated, they're feeling air hunger, and they start breathing rapid and fast to try and compensate. But because they're breathing fast and shallow, 50% of the air that they've taken in is wasted in dead space. Now, if, for example, we ask this person to breathe slow, and we'll say down to 12 breaths per minute, and I'm going to allow the tidal volume to increase proportionately to 500 mil. So the individual is still taking in 6 liters of air into their body. But how much of that air is getting down into the small air sacs? Well, we subtract dead space, 500 minus 150, and that gives you 4.2 liters. So already you see that when the person is breathing slower but slightly fuller breaths, that alveolar ventilation is increasing quite significantly. Now, we could go one step further and slow down breathing to 6 breaths per minute and increase the tidal volume to 1 liter. So we have 6 liters here. And then we look at alveolar ventilation. We have 6 multiplied by 1000 and subtract dead space is 150, and that gives us 5.1 liters. So it's kind of ironic that the people who need alveolar ventilation, their breathing is typically fast and shallow, and it's entirely the wrong way to breathe if the goal is to alleviate suffocation. So there's a significant difference between 3 liters entering the small air sacs in the lungs versus 5.1. And that's been looked as well with altitude. You know, I remember somebody coming in with chronic heart failure, and we use pulse oximeter, just finger devices. And she was desaturating down to 92% just walking across the room. And what I had her put her hands either side of her lower ribs and to slow down her breathing. and we increased our SpO2 within about 2 to 3 minutes up to 96%. And that's normal, you know. So I would say for people with COVID as well, especially when they're desaturating, very important to change breathing patterns. Don't breathe fast and shallow because it's so uneconomical, and you're looking to breathe slow and breathe low. Yeah.
That was fascinating, Patrick. Do you still have the diagram actually? Just
no, because it kind of, but I can send something on to you. I can send a screen. It's in the book as well. You'll see it. So I don't know what section it is, but you'll find the exact, the maths there.
It's incredible to just think that with a simple exercise like that, you can improve the oxygenation so quickly and so efficiently. And we have so many questions coming in. Can I ask you, actually, when you started breathing through your nose and you went to see Buteyko, how quickly did your asthma improve actually, and what medications did you take at the time beforehand?
The medication that I had back in we're talking about the late 1990s, I was on Unifilin, and I was on that for years. That was a tablet that I was taking every night. And from time to time, then I was on oral steroids. And I don't think I was always on a steroid medication. I had a lot of reliance on bronchodilators, Ventolin, Unifilin. And I also had another one, and I'm not sure, was it Pulmicort? And it could have been Pulmicort, but I can't think of it now back then. But I did my...
Yes. You started these medications?
I always started these medications 5 or 6 years of age. My doctor didn't put me on medication full-time at the very beginning. I was put on a medication called Intal. It was a yellow and white device. I never felt it made any difference to me. But as a kid in school, if I got wheezy, I knew another child with a Ventolin, and he'd give me a puff of his Ventolin. So that was when I was 7 and 8 and 9 years of age or whatever. And then I did go on full-time medication then, but it wasn't during the early years. It was when I got a little bit older. And I was hospitalized in 1990, I think, in 1994. And I spent 2 weeks then in hospital, 2 weeks, one in Blackstone Hospital in Dublin. And I went skiing in Andorra, and I ended up getting hospitalized there as well.
Right. And with an asthma attack?
Yeah, primarily with asthma attacks. Mm-hmm. And when I started putting this into practice, I would say that I had about 40 to 50% reduction of my symptoms in 1 week. And it's from nose breathing, but it wasn't just from nose breathing. I felt quite suffocated when I first switched from mouth to nose breathing. I didn't have the exercises that I have now. But, you know, typically we would expect a 50% reduction of symptoms in about 2 weeks. I'll just show you a trial on the Buteyko method that was first. There's about 20 clinical trials now, and they mightn't be all perfect, you know, and it's not always, nobody really knows what's the precise mechanism of it. But I'll just point to one thing. So just bear with me 1 second. So this was looking at 40, I think originally it was 170 individuals, and then by the time they matched them, it was a blinded randomized control study involving 39 people. 20 people were in the Buteyko group and 19 people were doing physiotherapy. The symptoms, there was no change in FEV in either group, but in the Buteyko group, the reduction to daily beta-2 agonist, which would be the rescue medication, it reduced by 90%, and their symptoms reduced by 70%, and daily inhaled steroid dose fell by 49%. Now there was no change in steroid there was no change in the control group. So zero change in terms of the reduction to inhaled steroids in the control group, but a 49% reduction in the Buteyko group. Now, there was no change in FEV1, but we have to bear in mind that this group of asthmatics had better asthma control. They had 70% less symptoms. they had 90% less need for rescue medication, and they had 49% less need for inhaled corticosteroids, with no deterioration in their FEV1. But the investigators in the study, they dismissed the Buteyko method because the FEV1 didn't improve. But they should have looked at it that the FEV1 didn't deteriorate despite improved control and reduction in the need for medication. Now, I'm just going to show you minute ventilation, because normal minute ventilation is resting minute ventilation is 4 to 6 liters per minute. But if we look at the minute ventilation of both groups here, the Buteyko group is 14 liters per minute. This is not when they're having symptoms. This is their everyday breathing patterns. And the control group is 14.2. Now, at the end of 12 weeks, from breathing through their nose and breathing less air, minute ventilation in the Buteyko group reduced from 14 liters down to 9.6. And the control group, it changed from 14.2 liters down to 13.3. But the interesting thing here is that the relative reduction in beta-2 agonist use in the Buteyko group was related to the proportionate reduction in minute ventilation. And that's all that Dr. Buteyko said. He said that people with asthma, he said, they breathe too much air, and it's their over-breathing that's feeding into their symptoms. And if we look at the minute ventilation in that study, breathing 14 liters of air during rest is too much. These people are breathing too hard, too fast, and it's their hard and fast breathing which is feeding back into their symptoms. So our objective is to show somebody to breathe light, to breathe slow, and to breathe low.
We can see this clearly in everyday practice, even though we don't talk about breathing, unfortunately, in medicine at all, except when we are measuring their respiratory rate, the vital function. We measure it every day to give us an inclination of how the patient is doing. And the sicker they are, the respiratory rate goes up. That's a clear indication to us that the patient is getting sicker and sicker and sicker, and we have to act. This is both in surgery and in general practice, as well as in acute medicine, where I am. So we know that our respiratory rate actually is a vital function and a sign that we have to act on. But very rarely do we actually talk about why it is in the medical practice. And what would you advise to us medics when we do see patients with asthma and COPD? What should we start thinking about from this aspect? How can we learn more about breathing? Where should we start?
Well, somebody with asthma, if their everyday breath hold time is low, it's almost that they are teetering on the brink of symptoms. And we should be looking at how do we, if I have somebody coming in here with asthma, my objective is to teach them to change their everyday breathing patterns, that it's through the nose, that it's light, that it's slow, and they're breathing through their nose during sleep. And I must show you as well a tape that we use just in case people are saying, oh my God, he's taping the mouths of people. Yeah. But our whole objective is to improve their functional breathing patterns every day through the nose, improve their breath hold time. And by doing that, we help to reduce their symptoms. So even if there is a trigger, their reaction to the trigger is significantly less. Now, IgE levels are typically regarded as a measure of or a marker of inflammation. There's only been one study looking at the Buteyko method in terms of IgE, and it showed that the Buteyko method reduced IgE levels. But unfortunately, the research is very scant with IgE levels. So we don't know what's going on, but we have to ask the question, does it make sense for somebody with a breathing related disorder to continuously breathe through an open mouth and breathe fast and shallow? They're taking unfiltered, dry and cold air, which is a normal bronchoconstrictor, and also they're breathing inefficiently and they've got impaired gas exchange. And also if they're breathing too hard and fast, it can disrupt their biochemistry. And it's not just the biochemistry, but also the biomechanics that's disrupted. So respiratory conditions are feeding in on itself. And physiotherapy is brilliant, but it doesn't teach nasal breathing, and it doesn't teach light breathing. So there's two components from physiotherapy which really there's two components that need to be brought into physiotherapy. Like if I'm working with somebody that's recovering, you can say somebody who's recovering from an asthma attack, they're on inhales, they're on oral steroids, for example, they may be on oxygen, etc. It would be also useful to bring them in a recovery program of small, gentle breath holds and just gently slowing down and calming down their breathing. Now, there may be something else to this. For example, with people with asthma and also with panic disorder, we deliberately have them breathe a little bit less air to give them a feeling of air hunger. And this may also be reducing their perception of breathlessness. And for panic disorder, I think it's a very good approach because there are two groups of people with panic disorder, and one group of people have a heightened sensitivity or fear of suffocation. And the fear of suffocation is feeding into their symptoms. So what we do is, with kind of a stepped approach, I give them a teaspoon of suffocation. And I continuously just gently give them a teaspoon of suffocation to desensitize them to the reaction towards suffocation, so that when they do feel suffocated in their everyday life, if the asthmatic is feeling suffocated, they can have some degree of panic and they can also start breathing harder and faster. But with the person with panic disorder feels suffocated, they too can feed into their symptoms. So, there may be a few different things going on, including the reduction to the perception of breathlessness.
I personally would like to thank you for your book and for all of the advice and the research that you brought together. You have sorted out my snoring. Thank you. And I think my partner is very grateful for that too. So your myotape and taping my mouth every night has been revolutionary for me and a lot of our friends that we shared it with. It's a very simple and effective method. And one must ask, in the midst of the chronic pandemic, not COVID, but chronic pandemic that we are seeing with diseases that are just escalating with the treatments that we are providing right now, one has to ask, no matter how much research we have, what are the side effects that we get from breathing in relation to steroids? And really ask ourselves as clinicians as well as patients, what are the things that we can improve that are simple, cost-effective, and low on side effects that we can incorporate in our daily practice? And I certainly believe that breathing is the number one thing that we should start learning and educating ourselves on, as well as our patients. And the book that you have written is extraordinary. Thank you so much for bringing all that research into one book. Just a reminder, guys, it's coming out February 15th, and we were very lucky to have a manuscript, and we really couldn't recommend it more from a medical point of view, both to our physicians as well as to our patients. So do have a look at it. We would love to ask you just a few more quick questions here, if that's all right.
Sure, of course.
Your time, it's really great. I can see you have a really big following and fans. One question from Sarah, I think it's quite important. When we talk about childhood and development, she actually asked us, if I find the exact question.
How can I train a 3.5-year-old to breathe properly?
Sure. About a year ago, we put all of the videos for children free of charge online. So if you put my name into YouTube and you put Patrick Mckeown children's breathing exercise, you'll see all of the breathing exercises are there. Now, first of all, we need to establish with children, why do they breathe through an open mouth? Is it because of obstruction or is it because of habit? And if it's because of obstruction, is it because of obstruction to the front of the nose, or is it possible that the child has enlarged adenoids? So typically what we do with young children is we have them wear tape And I'll just show you the tape just in case. And we start with tape during wakefulness. This here is the adults one. And I'll just show it to you. It's elasticated cotton tape. And it's stretchable. So there's a tension created now by the tape, which is drawing my lips together. And it's also activating the muscles here, the orbicularis muscle, to help strengthen them and to help to improve the tone around the lips that the child is bringing the lips together. I typically will always have the child wear tape during the day, and then I have them do the exercises to decongest the nose. And then we have them do the steps exercise, which you'll see online. But if the child is continuously ripping off the tape, even though they're doing the nose and blocking exercise, I have to suspect that the problem then is the back of the nose as opposed to the front. Now, when we consider enlarged adenoids, we also must consider it with development of the maxilla. If we have a child and their maxilla is set back, well then if you have a child with a setback maxilla and enlarged adenoids, the airway is compromised. And it's not enough just to look at the adenoids. We also need to look at the maxilla. And that's where a functional dentist can play a role. So my own daughter, I put her into an alpha appliance when she was 4 years of age, very light wire appliance. And because she had a high upper palate like mine, and a high upper palate, of course, is not ideal because the roof of the mouth is the floor of the nose. And this little appliance was stimulating the growth of her jaws and helping her jaws to develop. And because, of course, it's not just about the habit of mouth breathing, but it's also about genetics. It's genetics and lifestyle coming together here. So back to Sarah, all of the videos are free for kids. And we put them up there because we wanted, you know, children, the awareness to get out there. So yeah, so you'll see them all there.
Guys,
That's a question.
Sorry, yeah, the guys, the myotip, somebody just mentioned that they have ordered it, but unfortunately they don't have enough stock.
Yes. Well, we have loads of stock. But the problem is our postal service with COVID. It's taking 4 weeks to get to the UK from Ireland, which is typically it was about 6 to 7 days. Now it's 4 weeks. So hopefully everything will settle down. But we have, we've got, I've got 1 million strips in stock. So we've lots of stock.
There's a question from Alexandra. Any tips on how to breathe better while speaking? And she feels like she's gasping for air when she's speaking and mouth breathe when she's speaking then.
I think, you know, in terms of speaking, it's pretty impossible to be always nasal breathing during talking. You could do it, but you're going to sound like this. So you'll talk, and then you will stop. And then you will talk. You're not going to hold your audience. The main thing about breathing during speaking is not hear your breathing. And if you improve your everyday breathing and breathe through your nose during rest, physical exercise and sleep, increase your breath hold time. And when your breath hold time is higher, your ability to sustain a sentence is going to be longer. So if you're running out of air during talking, the likelihood is that your breath hold time is quite low. So you're not just running out of air during talking, but you'll also run out of air during physical exercise. You may also be breathing harder and faster during sleep. So what I'd say is just look at your everyday breathing patterns, practice nasal breathing, reducing the volume of air that you breathe, breathing low. I know I can only give you a little bit of it here, but if you can improve your breath hold time, your ability then to hold a sentence is going to be much improved. And that's, you see something in, I had an email with somebody coming in post-COVID, and this person is long COVID, and her breath hold time was 3 seconds, and she cannot speak a sentence. And of course, if your breath hold time is quite low, you're constantly struggling for breath. You're not even going to get the words out. So with her, you know, we don't start her off with slow breathing because her breath hold time is too low. I start her off with small breath holds. gently building her up, exposing her to air hunger. And, you know, that way then we can gently increase our breath hold time. As our breath hold time is increasing, her breathing is becoming slower, and we work with it that way. So there are exercises, you know, breathing recovery exercises, depending on the individual, their age, etc.
I can definitely attest to it as a patient. So before I learned about breathing and running to your work, I was always a mouth breather, unfortunately. And when I was speaking, I always had to take a big breath, and it was really quite obvious to me and to everyone. Once I started taking on the exercises, which are very simple daily, 1 hour a day at least, just become conscious of my breathing while I'm walking around in the house. First, I started taping my mouth while I was awake. So I got used to the idea of breathing through my nose, which I haven't done, I don't know, definitely over 2 decades. It was a very suffocating experience. I actually had to call Erica to help me through those first few minutes. So we tried put it together and we were practicing it. So we went through all of your exercises. And then the next day already, within 1 day, my brain started to get used to the mouth taping. And then I was doing the exercises with the nose that really cleared up my nose enough to be able to start comfortably breathing through my nose. And the third thing that was super important for my habitus is to relax my abdominal wall. I think a lot of us actually are tightening our abdominal wall to look skinnier, or whatever culturally we are used to stand up straight, you know, pulling your tummy. That's the proper way. But unfortunately for me, a lot of gymnastics created this feeling that I constantly have to tighten my tummy. As soon as I was able to relax, as you teach, relax the abdominal wall, then I was able to decrease the resistance against my diaphragm, which was pushed in with my stomach, and the breathing through the nose became much, much easier. So relaxation rather than deep breathing is what was key for me to actually shift. And within 1 week now, I can comfortably say that I can breathe without noise. I always show it off to my friends. Can you hear it? There's no noise. So it was really cool within 7 days to see that change in the nasal airway, the reduced resistance in my abdominal wall. And I can actually now consciously feel my diaphragm going down, which is very new for me as an upper respiratory breather who constantly just opens up the lungs, but now it's my tummy that goes out and my lungs stay the same. So I definitely attest to short breathing exercises at home, holding your nose a few times a day. I think we don't have to put a number to it, but just to do it consciously at the person's comfort in their day. Do it at home where it's safe, where you feel comfortable, and start when you're awake, and then you can continue with the tape over the night. And I was really shocked that I slept through really comfortably with it. I didn't wake up to remove it. I was scared that I would be suffocating because I'm used to it. And certainly slept like never before. And the best thing, I didn't have to wake up in the middle of the night to have to drink water because my mouth was always dry, unfortunately. And we looked at ENT before to see if I have to get an operation for my nose, if I have to buy anything to, you know, dilate my nose. And actually it was just that I couldn't breathe properly. I was properly one of those patients who almost was put on steroids because of recurrent upper respiratory chest infections due to my mouth breathing. So it's really revolutionary. And yeah, as a patient and as a medic, I'm really grateful to you, Patrick. Thank you.
Sure, I'm delighted. Thanks very much, Lena.
And that just reminded me of something that I've heard you say before, Patrick, that animals nose breathe and they only mouth breathe when they're stressed or sick. That's just super interesting.
Yeah, it's very interesting, and it's not just animals. Human beings, we were innate nasal breathers, and anthropologists looking at the shape of the human skull, they believe that mouth breathing may have started only about 400 years ago. And it seems to be linked with processed foods, with change of diet.
Mm-hmm.
So, because when anthropologists were looking at the skulls of individuals from upper middle class backgrounds who had access to sugar, they had a narrow facial structure. And because, you know, if you went into a natural history museum and you look at the shape of a skull, typically you will see it's a nice broad maxilla, and there's plenty of room for teeth, no overcrowding of teeth. So the human being, we should have plenty of room in the mouth for all teeth, and overcrowding of teeth is not a good sign, because it's not just that the teeth are crooked, but it points to the fact that the jaws have not developed properly. And if the jaws are narrow, then, for example, you have a high upper narrow palate. I think it's useful looking at photographs of Prince William and Princess Kate. And if you pull up a photograph online and look at William's mouth and count the amount of teeth that you can see, you will see that he has black triangles either side of his jaws, and you'll see his mouth is quite narrow. And then when you look at Kate Middleton, you will see that her mouth is quite broad, her maxilla is broad. You will see that she is about 10, maybe 11 teeth showing, and that points to a better airway. So when we smile, we shouldn't have black triangles. But that is one way. Now, both mouth breathing, but also extractions during orthodontic treatment can also assist with that. And there's two schools of thought in orthodontistry. One school of thought is that the teeth are crooked because the child has inherited dad's big teeth and mom's small jaw, and we need to extract teeth to make room for the existing teeth. The other school of thought is saying that the jaws are too small. We need to expand the jaws to make room for the teeth. So if you have a child and you're embarking on orthodontic treatment, if your orthodontist recommends you to do extractions, I suggest that you get a second opinion, because there should be perfect room in the mouth for all 32 teeth. And if we have extractions, it's making the size of the mouth smaller. There's not enough room for the tongue. And if there's not enough room for the tongue in the mouth, the tongue is going to go back into the airway. So extractions and orthodontic treatment can increase the risk of obstructive sleep apnea.
Sam just asked, what's the black triangles?
So the black triangles are, well, you'll see it, for example, if you look at, now, so say, for example, I don't have them now because I've had my jaws widened, and I had them widened when I was in my late 30s. You shouldn't see here, you can you don't see them here with me, but a black triangle would be that the person has very narrow jaw, and the problem with that is not enough room for their tongue. But if you look at Prince William, and the only reason I mentioned Prince William is because you'll find his photo quite easily online, and look at a comparison of Prince William versus Kate Middleton, and coming back through the generations, the human being, the face, the shape of the face is changing, and it's not changing in a good light. Our ancestors were innate nasal breathers. Of course, they were eating chewed foods, more breastfeeding, natural foods, etc. And yeah, there's a change in our lifestyle that's also impacting our aesthetics. But a good-looking face, when you see the individual smile, you'll typically see that they have a nice broad facial structure, and you will have an idea by counting the amount of teeth shown during the smile.
Sorry, how did you widen your jaw? I think somebody just asked.
I use an appliance. So there's a Dr. John Mew in the United Kingdom, and I also went to Dr. William Hang, who's based in Agora Hills in California. So a little appliance put into the mouth, and it sounds a little bit more extreme, but just with a little screw over time. Now, it did cause a little bit of gum recession. So, but at the same time, I wanted a bigger mouth to house my tongue, because I want plenty of room in my mouth for my tongue. I don't want my tongue falling into the throat. And that was the main reason of why I expanded to jaws.
That's amazing. So for quite a few asthma patients here, what would you advise them to start with? And is it a safe way to start with Buteyko method and your breathing method?
Yeah, you know, I'd start with nasal breathing. And if you're doing physical exercise, just slow down your pace a little bit in order that you can sustain nose breathing. If you're, for example, don't change your medication, of course. You have to continue with whatever medication you're on, especially inhaled steroid medication. But say, for instance, if you do get a little bit of chest tightness, or if you're feeling a little bit wheezy, sit down and start holding your breath. And just see, can you stop your symptoms if you catch your symptoms early enough by holding the breath? The interesting thing with asthma is when we feel chest tightness, we feel air hunger, and we respond to the feeling of air hunger by breathing harder and faster. But the harder and faster breathing is going to feed into airway narrowing. So the person with asthma, if you're feeling symptoms, you know, you have your reliever medication beside you. Sit down, but see, can you stop your symptoms? Because it will give you a great feeling of a control, that you start to see a connection between how hard and fast you breathe and how it's feeding into your airways. There are exercises. You could look at the children's program. You know, all of the exercise for children are going to be applicable. And if you're pregnant, though, don't do the breathing exercise if you're pregnant. If you have serious medical conditions, don't do long breath holds. Just do light, slow breathing. So, but yeah, for asthma, I would say go for it. And you'll find a documentary online. The BBC did a documentary on this back in 1994, and it's called Breathless, QED. And it was a Russian instructor. Now he doesn't have very good bedside manners, but he looks at 3 long-term severe asthmatics that were in a hospital in Edinburgh, and he had 5 days to make them better, and he made them significantly better in 5 days.
It's just incredible for someone like us who are seeing patients every day, and our main go-to is here's your inhaler, your nebulizer, and here's the 6th time that I'm prescribing you steroids. Every time I prescribe it, I shiver a little bit, and knowing the side effects of all these drugs, and knowing so little about breathing exercises that can make such a huge difference. Even if we need more research, once again, I just want to stress the importance that there is no side effects. And not using something that doesn't have side effects is already going against our Hippocratic oath, do no harm. So I certainly want to encourage everybody in the medical community to think about it, slow down the response against the usual, no, this is not what we were taught in medical school, and maybe consider that we should start teaching it in medical school. And our patients to also be mindful that they should ask for things from us. So the more the patients demand, the more we are able to respond, because there's the demand response. So are there any more burning questions from our lovely audience who has been with us? Shoot now or hold your peace. But also we will save the questions and we will diligently go through them with Erica, because we can see that everybody's really, really excited about this topic. And we'll try to write a newsletter to all of you to send out the answers. We might bother Patrick a little more with these questions to get an expert opinion, if that's okay.
Sure, of course.
Because it does seem like everybody's very excited about it. One coming in. Does the new book help with COPD? One question.
The exercise in the new book, there is a section on respiration, which is going to include COVID recovery. If you're interested in exercise for COPD, what I would suggest is go into YouTube and look at a video that I put out in March for COVID. the exercise are going to be the same. So you'll find a 40-minute video there. It's been popular enough, and a lot of people have used it for COVID. It's at 800,000 views, and you'll see a lot of comments underneath it. So we would use the same exercise for COPD, because of course, if people are affected from a respiratory point of view with COVID, that faster and shallow breathing, that feeling of air hunger, that breathlessness, we also need to help bring that down for COPD as well. So that would be a good point. The new book has got sections that have not been previously talked about in terms of breathing. The influence of breathing on diabetes, epilepsy, women's breathing, functional movement, lower back pain, sleep apnea, children's development, asthma, and so I think it's going to be an interesting one that hopefully it opens up the debate of the importance of breathing and also the function of the diaphragm, that it's not just for respiration. In terms of lymphatic drainage, in terms of massaging the gastrointestinal tract, in terms of the connection with the diaphragm, the emotions, the diaphragm as providing stabilization for the spine, the diaphragm and the connection with the upper airway dilator muscles. And all of this is interconnected. Anybody with emotional difficulties, with sleep issues, with breathing difficulties, all three are interconnected. If your emotions are off, your breathing is off. And if your breathing is off, it affects the emotions. If your breathing is off, it impacts your sleep. And if your sleep is off, it impacts your emotions. So we cannot just look at one function in isolation. We have to look at the emotions, breathing, and sleep together. And if you think of the number of people who have anxiety and PTSD and depression, and they do cognitive behavioral therapy, which is great. They may use medication, which is fine. But who is looking at their sleep? Who is looking at their breathing? So we need to be doing all these things. And cognitive behavioral training does not change respiratory physiology. And given that 75% of the anxiety population have dysfunctional breathing, I think it's very important that we help address that as well.
Especially now with COVID, we are talking about breathing,
Yes.
but we have in A&E, in emergency medicine and GP, we are just so many patients are coming in with anxiety and depression.
Yes.
And panic attacks, which we really are not well trained in to calm them down. Of course, again, we reach to medication, and of course we have the time limitations, which we always have to consider. But if there is the right time and place, once again, we should talk about breathing and maybe getting trained in it so that we can deliver it time efficiently in a very nice and safe place. Certainly your book covers so much, and it brings together all of the research that is out there right now. And I think it's such a good start for anyone who wants to get into breathing. And it's very scientific, it's evidence-based. Everything that we got out there right now is in that book. So if any physician wants to start their knowledge and see what resources they can give to their patients, it's a really good point to start with, isn't it?
Yeah, I spent 4 years putting the book together.
Thank you.
And I suppose I'd already worked with about 8,000 people as well. So you're seeing sometimes firsthand what you're seeing, and then you're matching that with what available evidence. And sometimes we don't know the answers, and sometimes the research on the ground is quite scanty. But I think it's changing. I think there's now a role for breathing in conventional management. I would love to see it change. I would love to see it for children, because if we're leaving children persistently mouth breathe, the window of opportunity is brief. And those kids, those mouth breathing kids, they will develop craniofacial abnormalities, quite likely, that they have for the rest of their life. That impacts their sleep, that impacts their development, that impacts, how well they do in life. And I would say that no child will reach their full potential if they don't have good sleep and if they don't have good breathing, and both go together.
And that's just one point to look at with our special subspecialization in medicine. This is a huge problem where the patient is not looked at as a whole. And when you take, well, you have a subspecialty for the left pinky nowadays. So you have a lung doctor, you have a gut doctor, a brain doctor, but unfortunately the body still works as a whole. And if we as specialists don't communicate with each other, then the outcome will be as the same as if we are not treating the patient as a whole. And when we think about that, we have 25,000 breaths a day. Every day we have 25,000 opportunities to control our body, to learn how to control it, because as you mentioned, the breath is connected to the autonomic nervous system, the parasympathetic and the sympathetic nervous system, and the enteric one, which means all of our body is connected through the breath, through these nerves. When you breathe in, you ignite your sympathetic nervous system, right? And when you exhale slowly, you actually initiate your parasympathetic nervous system, which calms you down. So if you want to calm down, just try it at home. When you're breathing out, right? You want to relax, you close your eyes. And that's the parasympathetic nervous system, which is a time when you want to digest, relax. And when you breathe in, you get excited, you're ready to run. So with your breath, it's clearly, even if we don't have enough research, it's just in front of us, right? It's literally in front of us, the truth about the importance of nasal breathing. And certainly, personally, I am just so grateful for not having a blocked nose now. So I think there's no harm to just bring a bit of common sense back to what we do, and always question why we are doing things. And just relaxing your body and breathing shouldn't really be as scary as it is.
I totally agree.
Yeah, and breathing is free as well.
Well, I think this is why we don't have enough research on it, because it's for free. If we find out that breathing is really good for ourselves, well, some companies will have to pay for it, right?
Yeah, unfortunately, that is the healthcare system that we're in. Something that is a promise of profit is going to attract research, but it's changing now because information is so more readily available. And COVID has really put a perspective on breathing that people are starting to realize. So I think it's changing. I really do. We notice it with our own workload. It's doubled in 2020, which is great because we feel that the message is getting out there.
It is. And once your book comes out in February, we will definitely do a book club on it. So maybe in about 2 months' time afterwards, to give them time to read, I think it's 970 pages, if I...
It is, in a Word document. It's 190,000 words. So by the time it's typeset, I think it's going to be about 500 pages, but I'm not sure.
It's brilliant. It's really encompassing. So if you have a chapter in it that covers your disorder and you would want to discuss it, then come on afternoon tea on the website, and we have the book club on it. So you can register. Again, everything we do is for free completely, so that we are not tainted by industry money, and that we can continue bringing you guys the clear information that is evidence-based. So yeah, do come on the website in a month or so if you want to sign up to the book club. And maybe Patrick will again honor us, but of course that's a lot to ask for somebody who is so busy right now. We are already really, really grateful for you.
That'll be my pleasure. My pleasure.
So much. So guys, Patrick will be there. Look at the smiles and the happiness.
If I can bring in Maura, Linda, who I know, if we can unmute Maura, if that's possible.
Oh, Maura, of course.
Maura Collins.
Unmute. And I think now you have to unmute yourself, Maura.
Okay.
Perfect. Hello, Maura.
Hello, how do you do? Hi, Patrick.
Good, how are you?
Thank you.
Hi, Maura, how are you?
Yeah, very good. Yes. Actually, Patrick has made a big difference to my life. I've known him since about 2002. And oh yeah, I sing his praises. I have all his books. Unfortunately, I don't do as much of the exercises as I should, but I still do quite a bit. And I used to cough at night, and I hated my coughing, but now I don't cough, because as soon as I feel the cough is coming, I do the 5-minute breath holds. And it is such a comfort to lie down and feel the cough might come, or be afraid it might come, but no, I won't have a problem with it. I'll do this for 5, do this for 5, back and forth. That has been wonderful. I do try to keep my breathing not too fast. I always tape at night. And what's more, which is really interesting, in the morning, I'm not in any hurry to take it off. You know, I have to go downstairs and have my breakfast. But, I like it up there, you know, it's very nice. Yeah, so I owe you a lot, and I enjoy your books. What are you going to call your next one?
The publishers come up with a title called The Breathing Cure. I don't know if I'd use it, but I have to kind of go with what they suggest. So yeah.
They have a lot of power.
Well, it's the USA publisher, so I didn't want to have a different name in the United States first, the UK and Ireland. So I just said, just for simplicity,
we like the name. I think it's good. It is definitely the cure to a lot of the diseases that we see in hospitals. So I think it's good. Yeah. The breathing cure.
The two lady doctors, where are you practicing? Are you in Ireland or are you in America? Or? Where are you guys?
I'm in the West Midlands in the UK.
Okay.
And I'm in Sheffield.
You're in Sheffield. Okay.
A little bit close. We are quite close to the north. So we like it here.
Yeah, I'm quite concerned. I have a daughter, a doctor, and she has a 2.5-year-old, and he has his mouth open. But she lives with her mouth open. I think she decided it's cute or something. And it is, I just have to steel myself not to tell her to shut her mouth, because it ends up a row. Oh, it's really, you know, I don't know, poor doctors, they know everything, but do they know everything, you know?
This is the good question, and we love what you just said, because unfortunately for years and years in training, we are trained and then we think we know everything. And we actually have this curve, well-known curve. In the beginning, we know we don't know anything. Then all of a sudden we think we know everything. And then all of a sudden we know nothing. And then again, we have the curve up and down. And with Erica, we are very passionate about lifestyle medicine, because we have realized that we don't know anything again.
I'll just give you one more. I'll give you one more funny thing. I had to do some counseling at one stage, and a very experienced gentleman was my counselor. And he told me there were 3 groups of people who are highly resistant to counseling. And who do you think the 3 groups are?
Doctors, and doctors?
No, doctors, the clergy, and the police.
Yeah.
You just can't, they know everything, he says.
Yes.
You know?
We are trying to cure that disease right now on afternoon tea. And why we have these conversations is really to chat with all of you, to learn and to maybe mix that up with our daily practice so that we can bring better treatment.
And we have just as much to learn from, you know, all our audience. So we've got so much to learn from our speakers. I mean, today has been incredible listening to Patrick. But we have so much to learn from our audience, from the questions that you ask. It influences the way that we practice and how we approach people in our clinical practice. So that's why we love what we do on afternoon tea, because we get to hear from the patient's perspective as well, because we learn so much from you.
I mean,
you intend to...
Oh, sorry. I muted Maura because of the feedback. Sorry, guys. Sorry, Maura. I muted you by accident there.
We do have quite a lot of guests still here. So come on the camera if you feel like it, and have some live questions with Patrick. You can talk to him. Not often will you have that opportunity. If you have a question, do put up your.
Hello. Patrick.
Oh,
Can you hear me?
Hello.
My name's Ken. I'm in Austria. I've been diagnosed twice with sleep apnea. And when my kids were little, I was scared to wear the mask because I thought it looked like Darth Vader. And I was divorced, so they only stayed with me on weekends sometimes, and I didn't want to scare them. So I've never really got on with it. It hasn't really got much better, a little bit better, but my lovely wife has enrolled me in your course. So I'll be seeing you on the 11th, I think. And after listening to everything, I'm really positive and hopeful that I'm going to come up with some good solutions, and my health will improve, my sleep will improve, and her sleep will improve. So thank you.
Yeah, no, you're very welcome. It would be good for the two of you to attend it together.
Yeah.
Well,
And
I signed up for the Wednesday, and he signed up for the Thursday. So you're gonna have the pleasure of both of us for 2 days.
That's great. Great.
and if you tell our audience what is the course, how long is it?
I do 2-hour courses. One is for sleep, one is for respiratory issues, and one is for anxiety. They're 2 hours, and they're a small group of people. It's about 20 people. So I give individual feedback. I guide people through the exercise, and the cost of it is $95. So it's about £60 for the 2 hours.
Wow, that's amazing.
But they get the recording of it as well, so they can do a refresher that way as well.
That's phenomenal. You have another. Oh, hello.
Hi.
Hi, this is the first time I've joined you. I look after patients with COPD. I run a pulmonary rehabilitation for our NHS here. And I have a few patients, I would say 2 of them, who seems to be talking a lot about your techniques. And I don't quite understand it. So I decided to join you today to see what's, I have a clear understanding of what techniques they are using. Because initially, when I met them, they were really struggling, and they seem to be doing very well. So I just want to know a bit more, then I can sell it to my patient to say, look, this is what's happening, please do this and all that. And I think I asked a question, which you explained very well, with the alveolar distractions and all that, which I do understand. So again, I'm going to sell it to my patient to make sure that they start using it. So it's a very good thing I joined today.
Fantastic.
Thank
Thank
you.
you very much.
Incredible.
Yeah.
Glad to hear your patients are doing well. So if the
Yes.
clinicians would like to learn your method, I believe you also have a training for clinicians as well.
Yeah.
Yes, we do instructor training as well. The
Okay.
website is buteicoclinic.com, and that's BUTEYKO
Okay.
clinic.com. So
Yes.
we do 2-hour sessions
Okay.
for clients and for students with different conditions. And then we have instructor training as well.
Okay.
Mm-hmm.
Okay.
The link is in the chat
Thank
for
you.
anyone who's interested.
We will send out. There was one question actually about breathing, food and breathing. I just wanted to put it out quickly that when we eat a lot, there was a mention about plant-based diets, which is lower in caloric intake than a meat-heavy diet. So I believe, again, the role of diaphragm is at play here, isn't it? If you eat quite a lot at night, it's pushing against your diaphragm.
Yeah, it seems to be, and I haven't looked down the whole food route all that much. It was a very interesting book written back in the 1930s, and it's called Nutrition and Physical Degeneration by Weston Price.
Mm-hmm.
And he looked at when individuals switch from their traditional diet over to a processed diet, he noticed that first generation children became mouth breathers. And it wasn't just that they had dental decay, but they had craniofacial abnormalities as a result of the diet. And this book was written back, I think it's 1936 it was published. There's no question that there's a connection between diet and breathing. There's no question. And sleep as well, of course. If we eat late at night, if we drink alcohol late at night, it's going to impact our sleep as well.
Mm-hmm. Mm-hmm. Fascinating. So many aspects of the health. It's just, we have to look at the whole. Again, the conclusion is is really everything that we do will impact our outcome, and that outcome will come back to bite us, and the circle goes on. So we are very conscious of your amazing your time, Patrick. So we wanted to see one more time if anybody had any more questions. Then you can put your hand up. Last question here, and we can bring you on the camera. Thank you very much. Everybody's very grateful. Perfect. All right. So then, if no one has any more questions, we will bring it to a close. It has been the longest afternoon tea we ever had, and we are so grateful for you for coming. I would like to invite you to connect with us. We are on Instagram on Afternoon Tea with Docs, on Facebook with the same tag, and this recording will be on YouTube, so you can come back and rewatch it. And please do subscribe for YouTube. It does help us to continue these completely free sessions that are not funded by industry. It is done completely on our free time with Erica on the weekends. So your subscription is greatly appreciated. Every Sunday we are here at 5 p.m. live, bringing you experts from different walks of life. All of them are doctors and evidence-based clinicians. So you can subscribe to our free session next Sunday, which will include a respiratory physician who is dealing with COVID right now in the pandemic, as well as a consultant physiotherapist who is dealing with long COVID patients. So they will be going through what they're seeing and how they're treating it in the hospital. And do visit our website, afternoonteawithdocs.com, and we can continue this conversation there on our open forum. You can become a member, again, completely free of charge. Everything is just here for you to learn and to educate each other on things that we don't have time to tell you in our daily clinical practice. So if you do have any questions, you can come and chat with us on the forum, or send us an email, or catch us on any of the other socials. Thank you so much. If you enjoyed this, do fill out our form that will come up here for feedback form, or answer it on your email. We will send it out to see if you have any questions, burning feedback. And of course, if you're interested in the book club, check out Patrick's new book on February 15th. And if you can close this, Erica, thank you. Check out Patrick's book that will come out February 15th, and then we'll have the book club in 2 months' time, so that you have time to read it. And we'll see you there. Okay, thank you so much, guys, for coming. Thank you, Patrick, so much for everything you do, all the stuff that you put up on YouTube, for pushing against the medical community with kindness and science. And I think we are starting to hear your important message, because our patients can't live without it. So thank you for what you do. We are really, really grateful.
Thank you so much. It was a pleasure.
Thank you.
Thank you.
Bye, everyone. Thank you very much. Hope to see you next Sunday. Bye, guys.